Hello everyone, myself Dr. Bhupendra Singh Rajput, leader of Department of Oral and Maxillofacial Surgery, IIDS. Today we are discussing with orthognathic surgery. Our content is principle of orthognathic surgery, diagnostic and treatment planning in surgical technique. Principle. There are three kinds of treatments are available when malocclusion is caused by severe skeletal discrepancies. Growth modifications in the growing children. Dentofacial orthopedic can alter their expression of growth to some extent. Orthognathic camouflage dental compensation for skeletal deformity or orthognathic camouflage not only can compromise or even impair the aesthetic but also can jeopardize the stability of the result. This option may also increase the treatment time. Orthognathic surgery combined orthodontic and a surgical correction is considered the best treatment modality for dentoskeletal imbalance once growth has reached. The treatment objectives are functional, aesthetic, and stability. Functional and aesthetic deformities often exist concurrently when they do. Treatment should be designed to correct both. When correcting a functional problem, the clinician has the opportunity to improve facial aesthetic at the same time and should make full use of it. The treatment of patient with poor function but good aesthetic is particularly challenging in these cases. Careful planning must avoid worsening the aesthetic while providing optimal functional relationships. Aesthetics. Facial appearance is often the patient's main concern. It is the patient's perception of what is aesthetically wrong that is paramount, and one of the clinician's first tasks is to establish the patient's aesthetic concerns. As Leo Tolstoy said in the childhood, I am convinced that nothing has so marked influence on the direction of a man's mind as his appearance, and not his appearance itself so much as his conviction that it is attractive and unattractive. Aesthetic imbalance is often the result of significant dentoskeletal deformity. In some cases, the aesthetics can be improved by surgery alone, although the functional problem will not necessarily be treated. An example is accepting a class 2 malocclusion after surgical advancement of the chin for a patient with mandibular anteroposterior deficiency. In contrast, for a patient with vertical maxillary access, may be possible to achieve a class 1 malocclusion by orthodontic treatment alone. However, an ideal aesthetic result is not possible because the orthodontic placement of the teeth dictate the surgical moment and ultimately the facial changes. The practitioner must carefully assess patient with musculoskeletal deformities before the commencement of orthodontic treatment. Accurate pre-operative orthodontic and a surgical planning that consider the indicated surgical moment is necessary to ensure that not only good functional result but an optimal aesthetic outcomes as well. In this figure, illustrate a case in which the dentition has been compromised for a skeletal vertical maxillary access and a mandibular anteroposterior deficiency have been achieved. However, the aesthetic result is poor. In this figure, illustrate an acceptable result after surgical compromise. Patient in figure decided against surgical correction of her class 2 malocclusion and a vertical maxillary access dentofacial problem. Orthogonal compromise treatment consists of the extraction of a first maxillary premolar, retraction of a maxillary incision, and establishment of an occlusion. 4 months after beginning orthodontic treatment, the patient felt her appearance was worsening and realized that this treatment option would not be accepted to her. It was then decided to decompensate the maxillary incision to be open the extraction space in the maxilla. The surgical treatment plan consists of a two piece of leaford, one maxillary osteotomy, superior pulpogenation of the maxilla, and the surgical closure of the extraction space by advancement of the posterior maxillary segment. The mandible would aut- auditorable and the chin would be surgically advanced by means of sibling genioplasty. In this case, a accepted surgical solution could be found. However, in some cases, the surgical compromise for an orthodontic compromise may be limited from either an aesthetic, functional, or stability point of view. In some orthodontic compromise cases, the compromised dentition may limit salvation or even make it impossible. Now, the stability without stability, the achievement of good functional and pleasing aesthetics is obviously not acceptable. Certain orthodontic tooth movements have questionable stability. An example is extrusion of tooth to correct a skeletal anterior open bite. Any pre-operative orthodontic attempt to correct this type of open bite adds significant instability to the overall result after surgical repositioning of the jaw beyond their biological parameters. They will replace relapse into a more harmonious musculoskeletal relationship for the individual. In figure, state a case where the orthodontic treatment of an open bite lead to poor stability and unacceptable aesthetics. Occlusal stability at any moment is the result of sum of all the forces acting against the teeth. It has been shown that the use of sound, orthodontic mechanics, and surgical techniques will produce optimal stability, functions, and aesthetics. In this figure, a 15-year-old patient reported an inability to bite certain foods with her front teeth. She recalled that she had an open bite before orthodontic treatment. Her first premolar were removed as a part of the orthodontic treatment, which lasted 2 years. Her bite was good at the time of bone removal. Her frontal and proximal view revealed a convex proximal profile, maxillary vertical axis, and mandibular anteroposterior deficiency, while she had a class 2 anterior open bite malocclusion. In the skeletal soft tissue and a dental relationship is evident on the supplementary in this figure. Patient consultations, accurate treatment planning, and a meticulous or orthodontic and a surgical practice are essential to the achievement of treatment objectives. Just an important treatment objective, just an important however, and a communication between clinician and the patient as well as between the clinician and clinician. The first orthodontic consultation because people with irregular teeth and a jaw deformities usually seek treatment from an orthodontist. It is usually the orthodontic task at the initial consultation to discuss the possible need for a surgical procedure as a part of the treatment to achieve optimal result. During the first orthodontic consultation, a clinical examination is done and the appropriate record obtained. The record may be duplicate for the defined of the surgeon. Definitive orthodontic consultation, the final pre-treatment consultation takes place only after a systematic patient evaluation has been conducted, and the orthodontics and surgeons have agreed on a final treatment plan. It is mandatory that the patient and perhaps the parent or a suppose be well informed, patient follow instructions and as well as the general rule are easy to treat. Orthodontists and surgeons should develop their own method of informing patient and their gaining their confidence. It is important to keep explanation simple and to use the patient radiograph and a dental cast to demonstrate that the problem solutions for the problems should be discussed in the general terms and the need for the surgery explained. The importance of a pre-operative alignment of the teeth and the possibility of the bite not improving or even getting worse during this phase should be explained to the patient. Word choice is important for the orthodontic in the discussing the type of surgery required. Terms such as reposition, lengthen, and shorten should be used when describing the surgical procedure. The final and a more detailed explanation of the surgery should be left to surgeons. Treated cases with a similar problem may be used to demonstrate specific treatment objectives. For most patients, the treatment time is extremely important, but it is preferable not to give a specific length of time. It is important, however, to give the patient a general idea of the length of treatment and a treatment profile explaining various phases of the treatment. The sequence of the stages and the time each phase could take. The patient should be altered to factors such as bone density, periodontal disease, patient cooperation, age, and tooth extraction that might influence the treatment time and the surgical precisions. It is also important at the stage to inform the patient about the cost of orthodontic part of the treatment. Now we're discussing about the diagnosis and the treatment planning. The information from the systemic patient evolution from a database that the practitioner can use in completing a short problem list, which in turn lead to an initial diagnosis of the patient dentofacial deformity, careful assessment and a consideration of soft tissue, skeletal and dental positions are necessary to differentiate among various dentofacial deformity that can have similar patterns. For example, a patient with a class 3 malocclusion may have the skeletal characteristic of anteroposterior deficiency of the maxilla, anteroposterior excess of the mandible, maxillary vertical deficiency with overclosure of the mandible, or any combination of the above, provide a systemic guide to the differential diagnosis of the various dentofacial deformities and their in relationship. The following sections use a specific case to demonstrate the systemic evolution, the formation of database, the diagnostic process, and the treatment planning pathway. The diagnostic process and the treatment planning pathway, although the specific treatment of cases has not yet been discussed in the text. Now, case overview, the general patient evolution, there is the name, age, medical history, dental history. In the dental history, the orthodontic treatment by her general practitioners for 18 months. Currently, we are a fixed lingual retention appliances in the mandibular incisors area. Four impacted third molars are present. Men complain she find it increasingly difficult to bite through food with her incisors. Her left mandibular lateral incisor is malpositioned. She feels she has a toothy look. She has to stand to get her lips together. Now, clinical evaluation. The extraoral examination, frontal view, profile view, three-quarter view, intraoral examination, and others like slight marginal gingivitis in the incisor area and mouth breathing. In the specific evolution, radiographic evolution, cephalometric analysis, in cephalometric analysis, soft tissue analysis, skeletal analysis, and dental analysis. In panoramic evolution, post-enterocephalometric analysis, dental radiographic analysis, occlusal plane radiographic analysis. Now, in the dental cast analysis, the cast analysis confirms the clinical assignments. Diagnostic and a problems list. In the diagnostic, a skeletal diagnosis and the problems, soft tissue diagnosis and problems, dental diagnosis and problems, and other diagnosis and problems. The treatment objectives are soft tissue treatment objective, skeletal treatment objective, dental treatment objective. Now, treatment objectives. The clinician should now move on the specific treatment objectives for the case. When the considering the final treatment plan, three basic questions should be kept in mind. What are the aesthetic objective and which surgical procedures are indicated? What specific orthodontic treatment is required to facilitate the proposed surgery? What is the best sequence of treatment taking into account dental, periodontal, prosthodontic, and orthodontic treatment, surgical needs, and other requirements to obtain the desired result in the shortening time? Orthodontic treatment objectives and a possible solution are shown in the table 3.1. Surgical treatment objectives and possible solutions are now treatment plans. Preoperative orthodontic. The expected dental and soft tissue changes to be effected by the pre-operative orthodontic treatment are predicted and illustrated by the supplementary tracing and ortho-visual treatment objectives. The surgical removal both third molars and extract both secondary molars, retract the incisor slightly and maintain upper lip support, align the arch and close the extraction space. Establish a good arch form to be compatible with mandibular dental arch. In the mandibular arch, surgical removal both for third molar and extract both first premolars. Retract the incisor to increase the overjet and create class 2 malocclusion. Level and align the arch and establish a good arch form to be compatible with the maxillary arch. Make no attempt to close the open bite by extrusion of incisor or intrusion of molars. The surgical visual treatment objectives outline report one maxillary ostomy to superior repositioning the maxilla both the establish ideal tooth lip relationship and to allow the mandible to auto-rotate and close the open bite. Bilateral sagittal speed ostomy to advance the mandible. Vaginoplasty to advance the chin. Post-operative orthodontic. In the post-operative, the light 3.5 quarter inch elastic with slight class 2 vector to guide the occlusion. After 3 to 4 weeks, heavier up-down elastic finalization of the occlusion. The retention, the mandibular fixed intercanine retainer, removal maxillary appliances. Results. The achievement of the pre-operative orthodontic goals is to illustrate in the figure. The neat result of the treatment is demonstrated in case demonstrate a systemic approaches which is achieved by listening the problems under the following categories: soft tissue, skeletal, dental, and other successful treatment planning. Must also consider the interaction of the specific solution, the consequence of the various steps, and the impact the steps are likely to have on one another. Now, aesthetic objectives and a surgical indication. In class 1 malocclusion, scenario 1, this patient has a class 1 malocclusion, mandibular enterodeficiency, and a good chin shape. The solution is to use orthodontic to create a class 2 malocclusion along with the surgical advancement of mandible. Now, a specific orthodontic treatment required to facilitate the surgery. Single jaw surgery with mandibular repositioning, single jaw surgery with maxillary repositioning, and a two jaw surgery with maxillary and mandibular repositioning. Single jaw surgery with mandibular repositioning. Here, it is important for the surgeon to understand the orthodontic decision-making process, as it is for orthodontic to have a good understanding of the pre-surgical orthodontic requirement. Knowledgeable practitioners not only have good interprofessional communication but also have improper treatment result. The maxillary dentition, especially the incisors, will determine the new vertical anteroposterior and transverse position of the mandible. The anteroposterior and a vertical position of the chin may be altered by means of an genioplasty. These positions will be influenced by the prominence and shape of the chin as well as the labiomental fold. For example, when a patient has a class 2 malocclusion and a mandibular anteroposterior deficiency combined with a microgenia, the chin should be advanced by means of genioplasty. A second example is the patient with a class 2 malocclusion who has either a mandibular dentioalveolar process that is anteroposteriorly deficient or a macrogenia. The surgeon should consider two alternatives: advancement of the mandible by means of bilateral sagittal split osteotomy combined with a reduction genioplasty, a total subapical mandibular osteotomy with advancement of the dentoalveolar process. In the figure, a class 2 malocclusion and in A position, a class 2 malocclusion and a mandibular anteroposterior deficiency. In B figure, the dent orthodontically prepared maxillary arch and a favorable position of the mandibular incisor allow the surgeon to advance the mandible into a class 1 malocclusion and an ideal aesthetic position. Now, in second one, figure A, diagnosis class 2 malocclusion and a mandibular anteroposterior deficiency in the macrognathia. The elastic requirement demand a surgical advancement of the mandibular and the chin. In B figure. Now, in this figure, dentoalveolar anteroposterior deficiency in B, surgical advancement of the mandible combined with reduction genioplasty. In C, advancement of dentoalveolar part of the mandible by means of total subapical osteotomy. In both surgical options, the maxillary incisors determine the amount of surgical advancement and final aesthetic shape of the chin area, either by the amount of chin reduction necessary of the amount of lower lip advancement resulting from the advanced dentoalveolar segment. In the orthodontic consideration, patient with a mandibular anteroposterior deficiency and a class 2 malocclusion should not undergo excessive retraction of the maxillary incisor because that approaches would reduce the upper lip support and limit mandibular advancement. The desired soft tissue position of the lips and the chin as determined by the visual treatment objective should show the orthodontic where to place the maxillary and the mandibular incisors. From this placement, the orthodontic can reduce the linear extent of the mandibular advancement. The desired incisor position will also help determine the correct extraction pattern. If the extraction are indicated, patient with a class 3 malocclusion and the mandibular anteroposterior access may require the mandibular incisors and the molars to be decompensated. Once again, the desired soft tissue position, as determined by the visual treatment objective, will indicate the linear extent of the setback. This information will help the orthodontic determine the ideal incisor position. In cases with the mandibular anteroposterior deficiency, there is often dental crowding and a accentuated curve of SP in the mandibular arch, which are conditions requiring tooth extraction. Three extraction patterns may be implemented depending on the conditions. Crowding in the anterior mandible and no crowding in the maxilla. The mandibular first premolar should be extracted. After mandibular advancement, a class 3 molar and a class 1 canine relation will result. Extraction of the first premolar will also allow for more retraction of the mandible incisors where required. In second, the crowding in the posterior mandible and no crowding in the maxilla. The mandible section second premolar should be extracted. This will allow less retraction of the mandibular incisors. This extraction pattern will result in a class 3 molar and a class 1 canine relationship after surgical advancement. In third, the crowding in the dental arch of the both jaw require extraction in cases require a large overjet. The maxillary second premolar and the mandibular first premolars should be extracted, keeping in mind the principle discussed in the two previous extraction pattern. The term and second, first and the second premolars in both arts should be extracted. Now, single jaw surgery with a maxillary repositioning. The mandible, especially the mandibular incisor, determine the new anteroposterior position of the maxilla in figure. The mandible, the surgeon may alter the vertical height with inferior or superior repositioning of the maxilla. When maxilla is superiorly repositioned, vertical maxillary access or downgrafted vertical maxillary deficiency, the mandible will auto-rotate around a point at the condyle. The anteroposterior position of the maxillary incisor is determined by the anteroposterior position of the mandibular incisor after auto-rotation. Transfer discrepancies, narrowing or widening, vertical occlusal plane discrepancies, open bite and in interdental spaces in the maxillary arch may be corrected by segmental surgery. When the maxilla is also vertically excessive, superior repositioning of the maxilla will result in some advancement due to the anterior rotation of the mandibular incisors caused by the auto rotation of the mandible. If necessary, the orthodontic should compensate the incisor for this added advancement of the maxilla. This may entail retract the mandible incisors slightly or may necessitate two jaw surgery if the anteroposterior discrepancies become too large to be treated by single jaw surgery. Now, orthodontic consideration. The orthodontic and the surgical visual treatment objective determine the ideal maxillary and the mandibular incisor position. Bear in the mind that auto-rotation of the mandible will alter the anteroposterior position of the incisors. Maxillary anteroposterior deficiency often result in the crowding in the maxillary dental arches, and extraction may be necessary to accommodate all the teeth. The extraction pattern will implemented depending on the conditions. Crowding in the anteromaxillary arch and no crowding in the anteromandibular arch. Extraction of the maxillary first premolar will result in a class 2 molar and a class 1 canine relationship after surgery. Extraction of the first premolar will also allow more retraction of the maxillary incisors. And second, the crowding in the posterior maxillary arch and no crowding in the mandibular arch. Extraction of the maxillary second premolar will also result in a class 2 molar and class 1 canine relationship after surgery. Crowding in the both arches, the principle described in the two previous extraction pattern also apply here. Additionally, where a large overjet is required, the maxillary first premolars and mandibular second premolars will be extracted. In cases where the segmental surgery of the maxilla is planned, that is, for the surgical correction of open bite, extraction of the first premolar is preferred because it makes the orthodontic segment alignment easier. The interdental osteotomy may be placed in one of two positions between the deviated root of the lateral incisors and canine, or between the deviated root of the canine and the first premolars. Placing the osteotomy between the deviated root of the lateral incisors and canines has significant advantages. The surgeon has control over the intercanine width, which ensure a good class 1 canine relationship. Furthermore, before surgery, the canine root is deviated distally away from the interdental osteotomy site, achieving the distalized canine root angulation that most clinicians aim for the completed cases. This is important in the post-surgical orthodontic cases because a large canine root that requires distal movement can add many months to be finishing phase of the orthodontist. Finally, with this method, the surgical side is more accessible and the interdental osteotomy is easier because the alveolar bone is thinner in this region. In this figure, three pieces leave for one maxillary osteotomy with the interdental osteotomy between the maxillary interincisor, lateral incisor and canine. We step in this occlusion between the anterior segment, the incisors and the posterior segment canine through second molars bilaterally. The roots of the canine and the lateral incisor are deviated. Shorter period of the post-surgical orthodontic is required to correct the canine and the root positions. In the figure, second one, a three pieces Lefort one maxillary osteotomy with interdental osteotomy between the canine and premolars. In B step in the occlusion between the anterior segment, canine and incisors, and the posterior segment, second premolars through second molars, the root of the canine and the second molars are deviated. A longer period of the post-surgical orthodontic is required to move the large canine root into a more correct distillation inclination. Placing the osteotomy between the deviated root of the canines and the first premolars also has its advantages. This site is sometimes preferred when a natural step exists here in the pre-treatment maxillary arch, even though this site may be more approximate fourth place for the segmental osteotomy. It is necessitated significant post-surgical orthodontic work because the canine root must be tipped forward away from the osteotomy site, and this root angulation then must be corrected. This site is also prepared when the first premolar extraction space are to be closed surgically. The orthodontist must ensure that the intercanine dimensions are coordinated. In the figure, in this figure, low angle case with a 10 mm superior reposition of the maxilla, the mandible will rotate 10 mm superiorly and a 3 mm anteriorly. In the B figure, high angle case, a 10 mm superior repositioning will result in the 6.5 mm anterior rotation of the mandibular incisor. Counterclockwise rotation of the mandible will rotate the mandibular incisor anteriorly, while clockwise rotation will rotate the incisor posteriorly. This will have a significant effect on the final anteroposterior position of the maxilla. Clinician must ensure that the mandibular dental midline coincide with the facial midline. The maxillary dental midline can be corrected by the surgery. Finally, when the segmental surgery is indicated for narrowing, widening, and the vertical changes or closure of the interdental spaces, the root of the teeth advantage adjacent to the interdental ostomy should be deviated. Two jaw surgery with maxillary and mandibular reposition. When two jaw surgery is performed, surgery on the maxilla is usually first. Therefore, the final position of the mandibular pulp will be determined by the repositioning maxilla and the principle of the single jaw surgery and the mandible repositioning then apply. Now, orthodontic prediction tracing here a mandibular advancement plan in the 5 steps. In the step 1, create the original tracing by tracing the hard and the soft tissue without analysis lines on a separate sheet of acetate. In this case, the facial depth angle and the facial counter angle are used as an indicator of the ideal hard and soft tissue position, respectively. The facial depth angle is formed by passing a line from nasal through a point and the Frankfurt horizontal plane with maxilla in a good position, male 90 degree, females 89 degrees, and an extension of a N and A line should go through pube. The facial counter angle is formed between the upper facial plane and lower facial plane, 15 degree for male and 13 to 17 degree for females. Also draw a vertical line on the mandible posterior to second molar, representing the vertical ostomy lines of the sagittal split osteotomy. Draw a horizontal line on the chin, representing the genuplasty ostomy line. The step 2, in this case, the clinical and cephalometric assessment of chin shape indicator advancement genioplasty when begin the prediction tracing by tracing the mandible anterior to the vertical osteotomy line and above the horizontal osteotomy line in red on a clean piece of acetate. The teeth, lower lip, and the chin are traced in a dotted line. Draw the ideal soft tissue chin shape on this tracing, bearing in mind that soft tissue changes in relation to hard tissue. Repositioning of chin is 0.9 ratio to 1.0. Draw in the actual required the bony advancement by sliding the prediction tracing to left until the predicted soft tissue conquered. With the soft tissue on the original tracing, the soft tissue Pogonian should now be at very close to the desired horizontal position, and the shape of the chin should be aesthetically pleasing. Trace the occlusal plane. In this case, the mandible occlusal plane level. However, patients with a class 2 malocclusion often have deep bite with an accentuated curve of speed. Preoperative versus postoperative leveling of the curve of speed should be considered carefully because the choice affects facial aesthetic, the amount of surgical advancement, and need for genioplasty. An excessive curve of speed should be leveled up before surgery in the following cases. When the chin needed to be advanced the same distance as the mandibular incisor, when little vertical increases in the lower facial height is indicated in high angle cases. The vertical increases in slightly more than a lower angle cases because of the stiffness of the occlusal plane. when less discompensation of the incisor will necessarily achieve the desired gene projection. The curve of speed should not be revealed prior to surgery in case where a clockwise rotation of the distal portion of the mandible will be advantageous. For example, where the incisors need to be advanced more than the chin, where the anterior vertical height of the lower third need to be increased by the amount of the excess of overbite, where a deep labiomental fold usually present in the deep bite will improve because of the advancement of the mandibular incisor and the downward rotation of the chin. In taking above into the account, the clinician should choose the plane of advancement. The mandible can be advanced along one of three occlusal planes. The functional occlusal planes, the molar incisor plane of the maxilla, the molar incisor plane of the mandible. In this case, all three planes are the same. In step 3, slide the prediction tracing to right along the chosen occlusal plane, in this case the functional occlusal plane, until the bony pogonian coincide with the facial deep to the line and the soft tissue pogonian coincide with the lower facial plane. The soft tissue should take precedence and since it will determine the aesthetic results. In the step 4, trace the rest of the facial structure. The maxillary teeth are drawn in dotted lines. It is now clear that the mandibular advancement has resulted in the anterior crossbite. The question is, can teeth be orthodontically positioned in their ideal relationship to bone and to each other in new jaw relationship? The clinician has various options. Retraction of the mandibular incisor with without extraction, advancement of the maxillary incisor, less advancement of the mandible, and increasing the advancement of the chin. In the step 5, various cephalometric parameters may now be used on the prediction tracing to place the teeth in their ideal position in each arch and in the relations to each other. Draw the incisor in their best possible position on the prediction tracing. In step 6, the predicted incisor positions are now carefully studied in this case. The mandibular incisor will have to be predicted. The clinician, however, should guard against excessive traction of the maxillary incisor, which would undermine the lip support and limit the mandibular advancement. The maxillary arch in the class 2 cases often need some expansion to accommodate the mandibular arch part. After advancement, this expansion in turn often offers sufficient space for ideal positioning of the maxillary incisors. Extraction of the premolars, first or second, however, may be indicated where crowding and occlusal curve are present. During 1 mm of arch, leveling will increases the anteroposterior arch length by 1 mm. However, there will be an approximately 1 mm increases in arch length from every 1 mm of expansion the arch at the canine area and 4 mm in increases for a 1 mm arch expansion in the molar area. Let's we take tea time for 10 minutes. Now, let me start with the surgical techniques. Our knowledge and understanding of all the aspects of orthognathic surgery have grown considerable during the past 2 decades. Diagnostic skills and treatment planning have become more sophisticated, and we have developed surgical techniques that enable us to treat most complex jaw deformities with confidence. This chapter presents surgical technique for three procedures most often used in the correction of the dentofacial deformities in a concise step-by-step format. Complications and their possible solutions are indicated. Orthognathic surgery require not only sophisticated and accurate technique but also the almost respect for the hard and soft tissue involved. The formulation of the plan involving accurate tooth movement by the orthodontics, accurate tooth movement by the orthodontist does not good if what following is inaccurate surgery, sloping technique, and And the orthodox surgery require not only sophisticated, accurate technique but also ultimate respect for the heart and soft tissue involved. The formulation of the treatment plan involving accurate tooth movement by the orthodontic does not go deep what following intact, accurate surgery, sloping technique, and disintegrate for the soft tissue that lead to unsatisfactory result. Good surgical technique involve the following: treatment planning, surgical routine, instrumentation. Now, the treatment planning before surgery, accurate and comprehensive surgical treatment planning involving cephalometric treatment, objective model surgery should be carried out surgical routine as much as possible. The surgeon should develop a routine for each procedure that will enable assistant and the rest of the surgical team to anticipate each step, thus increasing efficiency and decreasing operating time. The surgeon should clearly understand the surgical step of each procedure and be aware of a complication that may arise with each step. It is essential to have a basic routine from the selection of a scalpel plates to suture material. An established step-by-step operating technique also prevents intraoperative uncertainty and often eliminates post-operative complications. The details and sequence of a surgical procedure may vary from the surgeon to surgeon, but ultimate objective is the same. The surgeon must be able to clearly visualize every step as well as the sequence or to operate with the confidence and achieve the surgical goal and optimize result. Instrumentation. A large number of instrumentation are available to help the surgeon achieve the same goal. When the surgeons use a small selected group of instruments rather than a whole range of instruments, however, is less confusing to both surgeons and the surgical team. Now, the bilateral split ramus osteotomy. The first report of surgical repositioning of the mandible was written by V.P. Blair and published in the American Medical Journal Surgery, Gynecology and Obstetrics in July 1907. Since then, the surgical correction of a dentofacial deformities has developed into two not only a well-defined science but also a facilitating art form. The surgical repositioning of the mandible has developed from the life-threatening procedure to outpatient surgery. In some part of the world, the indigeneity of the procedure development of surgical skill have made it possible to achieve our surgical goal relatively quickly and atraumatically. The advent of a rigid fixation has also made post-operative recovery safer and more comfortable. The technique described in the following text has evolved over many years and because of its simplicity has been found beneficially in the training of a postgraduate student at the university. Now, step 1, the infiltration of soft tissue with vasoconstrictor. Infiltrate the area of dissection with a local anesthetic containing vasoconstrictor epinephrine in the concentration of 1 is to 1 like 10 minutes before surgery. Place the needle deep in the soft tissue, aspirate and infiltrate the area. The patient lips should be kept lubricated with steroid ointment throughout the surgical procedure. Now in the step 2, soft tissue incision. Make an incision through mucosa, muscle and the periosteum from just a lingual of the external oblique ridge, halfway up the mandibular ramus, superiorly to the mesial of the second molar inferiorly only. Leave at least 5 mm of non-keratinized mucosa buccally at the lower end of the incision for ease of suturing later. Now, third molar ideally should be removed 6 months before surgery. Partially erupted for erupted third molar present at the time of surgery, however, should be included in the soft tissue incision. The early removal of impacted third molar should be part of the treatment plan. If these teeth are still present at the completion of the preoperative orthodontic phase, the surgeon can either remove the impacted teeth at this stage and delay definitive surgery for at least 6 months to allow for bone healing, or go ahead with the definitive treatment and deal with third molar at the time of surgery. The step 3, buccal subperiosteal dissection. The Dissection must remain subperiosteal decisive, clean, and neat. The masseter muscle attachment should be maintained as far as possible without sacrificing adequate exposure. Strip enough of the masseter muscle to allow easy visualization of the osteotomy area. It is not necessary, however, to strip the entire masseter muscle attachment of the mandible. Proximal segment of the mandible will not be repositioned. In fact, it is important that apart from the auto-rotation, this segment be maintained in its original position and not be totally detached from the masseter muscle. Total stripping of the muscle increases dead space, which encourages swelling and hematoma formation and may cause devascularization of part of the bone, leading to necrosis. Now, step 4, superior periosteal dissection. Once the buccal and the lingual side of the anterior ramus have been exposed, place a notch ramus retractor over the anterior border of the mandible ramus and strip the lower fiber of the temporalis muscle. Attachment from the anterior border and a coronite process. Alternatively, a coronite clamp may be used to retract the soft tissue superiorly. Dissect the periosteum from the internal oblique ridge down to medial aspect of the retromolar area. Now the step 5, medial subperiosteal dissection and exposure of the lingula. The dissection must retain subperiosteal by keeping the periosteal dissector against the bone at all times. Start the dissection from the interior internal oblique ridge above and then dissect inferior to the region of the lingula. The lingula must be carefully identified and well visualized. In the step 6, identification of the lingula. The medial osteotomy should never be performed without positive identification of the lingula. The panoramic radiograph may be helpful guide. However, the lingula is often difficult to visualize because of the convexity of the internal oblique ridge. If visualization is difficult, the ridge should be reduced with a large trimming burr. If the periosteum is perforated, a brisk hemorrhage may be result and probably will originate from the vessel of the medial pterygoid muscle. However, if often subside spontaneously, do not stretch the inferior alveolar nerve at its entrance to the foramen, since this may result in the prolonged anesthesia of the lower lip. Now, medial ramus osteotomy, step 7. While aiming at the notch of the lingula, angle of the ramus osteotomy parallel to the occlusal plane. In the figure, using a 701 fissure burr or landmark burr, terminate the osteotomy must posterior to the lingula and ensure that the osteotomy is carried out through the lingual cortex into the medullary bone of the mandibular ramus. When the mandibular setback procedure will be performed, a small segment of bone should be removed superior to the horizontal osteotomy line. When the medial ramus osteotomy is terminated anterior to the lingula, the bone tend to split anterior to the lingula. The lingula and the superior part of the alveolar canal, including the nerve, thus remain attached to the proximal segment during the splitting procedure. This is one of the most common reason surgeons have difficulty to splitting at the superior aspect of sagittal split osteotomy. In the step 8, the vertical section of the osteotomy. Start the vertical section of the osteotomy from the medial osteotomy superiorly, staying just inside of the buccal cortex of the mandibular ramus. And inferior just visual to the second molar, ensure that the osteotomy is made through the cortex well into medullary bone, approximately 5 mm. The presence of an impacted third molar may make the osteotomy difficult. It should be treated as bone. However, the osteotomy made through the tooth. Ideally, third molar should be removed at least 6 months before surgery. In the step 9, removing the notch ramus retractor and placing a channel retractor. Place the channel retractor around the inferior border of the mandible remains subperiosteal at all time. Visibility may be increased by removing the mouth probe, closing the mandible slightly. In the step 10, buccal osteotomy of the mandibular body, start the buccal osteotomy of the mandibular body at the lower border and join it superiorly with the vertical part of the ramus osteotomy. Cut toward the mandible, feel the burr, perforated the buccal cortex and angle the osteotomy slightly obliquely and posteriorly. Ensure that the cortex of the lower border of the body of mandible is included in the osteotomy. The actual start of the sagittal split osteotomy should be at lower border and must include part of the lingual cortex. When placing the sagittal separator, instrument makes sure it engages the lower border so that this part of the mandible stay attached to the proximal segment. The surgeon should be carefully in case with the mandibular anteroposterior excessive, mandibular asymmetry, the excessive side, the unilateral condylar hyperplasia where the inferior alveolar neurovascular bundle tend to be sustained with UV close to the buccal cortex and the lower border. In this figure, the horizontal ramus osteotomy should be made parallel to the occlusal plane and the osteotomy should end posterior to the lingual in the fossa. In B, the distal segment will be positioned posteriorly and also tend to move superiorly in the mandibular setback case with the high occlusal plane. In this case, a small segment of bone should be removed superior to the horizontal osteotomy line to prevent the interface between the segment. In the C, the horizontal osteotomy should be carried out post the lingula, otherwise this will be a strong tendency for the mandible to split anterior to the lingula. Now step 11, drilling hole for a holding wire. The hole for a holding wire should be positioned in such a way that the proximal segment is directly distally. The direction of the anterior hole proximal segment should be posterior and that of the posterior hole distal segment anterior. The placement of the holding wire is positional. The author, however, feels that condylar position, the most important step of the procedure, is more accurate if perforated as a separate step prior to the placement of the screws. Once the condyle has been positioned, it is held in the press using a condyler in the figure. See in the figure, the buccal osteotomy is started at the lower border and joined superiorly with the vertical ramus osteotomy. In the B figure, the buccal osteotomy is angled slightly obliquely and posterior to enhance the start of the split. In figure C, it is mandatory to induce the lingual cortex in the buccal osteotomy to ensure that it forms part of the proximal segment at the start of the split. In a case where a mandibular advancement of the 6 mm is planned, the hole should be drilled 10 mm apart. After advancement of the distal segment past 6 mm, the hole will be 4 mm apart. In case 2, in case where a mandibular setback procedure of 6 mm is planned, the hole should be drilled 2 mm apart with the hole in the distal segment position anteriorly. If the hole are more than 4 mm apart after jaw repositioning, bone approximation between the distal proximal segment will be less accurate because of the long span of the wire and may lead to inaccurate placement of rigid fixation. Alternative technique, in the step 12, the drilling a hole for condylar position. A hole is drilled in the buccal cortex of the proximal segment and angled posteriorly. This hole will be serve as a purchase point for the condylar positioning during positioning before the tightening of the whole wire. Lavage. In step 13, wash the surgical area thoroughly with the saline solution and place a small wet sponge lightly in it. Once osteotomy cut have been performed on the one side, it is recommended that the surgeon complete them on the either side for splitting the mandible. Now, step 14, defining the osteotomy cut with an osteotome. It is important not to manipulate the jaw unnecessarily when they splitting the contralateral side, since this may cause hard and soft tissue damage on the side already split. Now 10 mm wide, the thin but Rigid osteotomy is used to step along the vertical osteotomy from the medial osteotomy downward to the buccal osteotomy. Keep the osteotomy just inside the buccal cortex and support the mandible at the inferior border with the general retractor. Seen figure. The osteotomy cut are only defined during this step. Make no attempt to completely separate the segments. Vigorous, indiscriminate tapping may fracture the buccal cortical plate from the distal segment, while failure to support the mandible during the step may cause trauma to the temporomandibular joint. Now, step 15, splitting the mandible. The actual splitting of the mandible can be divided into two stages. The first stage involves the initiation of the split. At the start of the split, the surgeon must be able to see that the lower border of the mandible is split toward the proximal segment and the second neurovascular bundle is intact and separate from the proximal segment. Now, step 16, the completion of the split to continue the separation between the distal and the proximal segment. The osteotomy is now replaced by a larger osteotomy and the small sagittal split separated by the larger separator and the instruments are rotated. Always ensure that the lower border continue to split with the proximal segment and that the neurovascular bundle is protected and intact. Now, step 17, the stripping the pterygomacetic slings. Place a curved periosteal elevator between the bone segment and at the inferior border of the distal segment. Proceed to strip pterygomacetic sling from the distal segment. This step will ensure that no green stick bony attachment have remained between the distal and the proximal segments. The neurovascular bundle should be protected at all times. Insufficient stripping of the pterygomacetic splints and inadequate removal of the bony attachment between the proximal and the distal segment will lead to difficulty in the repositioning the distal segment, inaccurate positioning of the condyle. Now, step 18 is stripping the medial pterygoid muscle and pterygostylomandibular ligament. The medial pterygoid muscle and the stylomandibular ligament are attached to the medial side of the angle of the mandible. Failure to strip from them from the bone may interfere with the posterior repositioning of the distal segment. This may distract the condyle from the glenoid fossa or rotate the proximal segment posteriorly, thereby increasing the relapse potential. Now, step 19, removal of the impacted third molars. In the author policy to remove impacted third molar at least 6 months before performing a bilateral sagittal split osteotomy because this is not always possible. It is often necessary to remove third molar during the sagittal split procedure if they prevent optimal bone in contact between the proximal and the distal segments. The clinician should be careful not to fracture the retromolar bone, lingual cortex, or damage the neurovascular bundle during tooth removal. Now, step 20, smoothing contact area of bone segment. Larger pear-shaped pholinite bar is used to smooth the medial aspect of the proximal segment to ensure bone contact between the segments and prevent nerve damage by sharp bony edges. Bone should not be removed from the lateral aspect of the distal segment because of the potential damage to alveolar neurovascular bundle. Now, step 21, the placement of the holding wire. Place 0.018-inch wires through the hole in the distal medial segment. When the wire are pulled through to prevent any damage to the promandibular joint. Now, step 22, noting the position of the inferior alveolar neurovascular bundle. The inferior alveolar neurovascular bundle is often visualized and dissected. During the splitting procedure, the surgeon should be attached of this visualization and make a mental note of the position of the neurovascular bundle to ensure safe placement of the bicortical screws. Now, the step 23, mobilization of the distal segment. The third molar or its socket after removal of the tooth will influence the placement of the bicortical screws. Thus, the position and the size of the tooth or socket should be noted to ensure later safe placement of the insufficient bicortical screws. Now, step 24, mobilization of distal segment. Remove the sponge placed during slack C. Mobilize the distal segment of each side by pulling it anteriorly while supporting the proximal segment with the index finger. Step 23, 25, selective odontoplasty and maxillomandibular fixation. Selective odontoplasty should now be performed as indicated by the model surgery using a diamond burr and a copious water cooling. Maxillomandibular fixation is then applied with the teeth in the blind occlusion. A preferable catheter split may be used when necessary. The use of acrylic split is not always indicated, where it is possible to achieve a stable occlusion and no segmental surgery is contemplated. The use of acrylic split is superfluous. The intercussion of the teeth can be observed better without the use of a split. The central incisors are fixed to first to establish the plant incisor relationship. The maxillomandibular fixation is then applied to the posterior teeth. It is important to place the wire with a vector as a sustaining the surgical repositioning. Now, in step 26, when the teeth removal of the bone from the proximal segment, when the teeth have been wired into the occlusal and the proximal segment have been pushed back gently, the bony overlap which should coincide with the planned setback amount will be evident. The overlapping bone should now be removed with the surgeon taking care not to damage the neurovascular bundle of facial arteries during the bone removal. There is no advantage to accurate fit or bone at the buccal osteotomy. In contrast, if the proximal segment is forced to fit tightly against the distal segment at the buccal osteotomy site, the condyle may be forced to far posteriorly or eccentrically in the fossa, leading to condyle sag. Thus, result will also be less stable if segments are forced together at the vertical osteotomy because the proximal segment may also rotate backward and downward. The small piece of bone we removed may be used as bone graft in the other area, that is where there is an intersegmental bone defect in the bilateral sagittal split osteotomies or Clifford 1 osteotomies. Now, step 27, the condylar positioning. A condylar positioning is placed into the hole drilled into the buccal cortex, and while the angle of the mandible is supported by extraoral digital pressure, the condylar should be positioned in its preoperative relationship to the fossa. Posterior digital pressure on the positioning instrument and the superior and slightly anterior extraoral digital pressure at the angle of the mandible will give the surgeon control of the proximal segment. This control, combined with an awareness of the anatomical relationship of the condyle and the glenoid fossa, should enable the surgeon to achieve the correct condylar position. Excessive force on the proximal segment during the maneuver may displace the articular disc in the fossa and lead to hemoatherosis on the joint effusion. Now, 28, tightening the holding wire. Hold the proximal segment in its desired position while the assistant gently tightening the hold wire. Now, step 29, placement of the trocar. The extraoral slab incision is made on the lower border of the mandible and just behind the gonial notch. The surgeon places the trocar through the skin incision. Ensure the tip of the trocar perforate the periosteum intraorally. The initial placement should be superior to the bone, avoiding damage to the neurovascular bundle or bony segment. Incorrect placement of the skin incision may damage the mandibular branch of the facial nerve, resulting in the palsy of the lower lip. Now, drilling bicortical holes and placing the screws. In the step 30, in step 31, the removing the maxillomandibular fixation and check the occlusion. The occlusion should not be checked immediately after removal of the fixation wire before assessing the final occlusion. Open and close the mandible gently. Translate it to be left and right. Then wait a minute and with light digital pressure under the chin, close the mandible and assess the occlusion. The occlusion should be exactly as planned. Do not accept an incorrect occlusion. There is no better time to correct a problem than at this stage. Thank you.